Thank you to the organisers for the invitation to contribute to this session. It's a provocative title, Cytoreductive Nephrectomy Post-CARMENA. I still do it. A trial in the New England Journal, a great trial in the New England Journal, says don't do it. But might there be another side to this story? Let's see if we can just stir the pot a little. For a talk on surgery in metastatic cancer, you've picked someone from the right hospital. This is Guy's Hospital in London, where I work, founded in 1726. And it's the banner above the hospital I really need you to see, highlighted by the red arrow. It's a banner displaying the founding principle of Guy's. Guy's Hospital for incurables. We're more optimistic about outcomes these days, but we do still manage metastatic renal cell cancer. As a surgeon in this field, you can feel like you're confronting powerful forces. Here are the surgeons in the hospital for the incurables, with the pillars of the New England Journal, the IMDC, and social media bearing down on us. In the face of these powerful forces, how can I possibly maintain that surgery still has a role? Well, here's how. Because regardless of the trials, medicine and surgery still require good clinical judgment. In this context, what do I mean by good clinical judgment? Well, you need to know the evidence, what it is and what it isn't. You need to know the uncertainties about the evidence. I mean, no trial is foolproof. You need to know how to apply the evidence in real life. Generalizability is absolutely critical. And crucially, you need to know your own results. The patients are managed by you, not the New England Journal. Let's explore some of these areas. In this field, you have to accept that there is uncertainty. For 10 years, we had interferon trials guiding practice in the sunitinib era. And now we have sunitinib trials guiding practice in the IO era. The evidence just seems to always be one step behind the practice. What about the CARMENA trial itself? Well, as I've said, it's a great trial. There's no doubt about that. But like any trial, it does have limitations. A huge number of centers in France participated, 79 in total. But only 50 patients a year were randomized. Now, France is about the same size as the UK, with a similar spectrum of urological practice. And the UK National Nephrectomy Registry shows that about 300 cytoreductive nephrectomies are undertaken per year in about 90 centers. So there are probably about the same number of candidates for cytoreductive nephrectomy per year in France. So 300 candidates and 50 randomized. So where are the missing 250 patients? Were they managed in one of those 79 trial centers, but simply not randomized? Did they undergo cytoreductive nephrectomy off trial because they were considered particularly suitable for it, possibly? That's the crucial bit. Did the best candidates for cytoreductive nephrectomy not get put in the trial? I think the question does have to be asked. Exploring some of the other uncertainties in the evidence. Well, missing data in any trial presents problems. I know that from the trials I've run. And that's because that data might allow more nuanced interpretation of the study or guide more nuanced decisions as a consequence of the study. This is a key table from the CARMENA paper. Outlined in blue, there were 226 patients in the surgery arm, but only 67 of them had a stage recorded. Only 66 with a nodal status. I think that's remarkable in a trial of surgery for cancer, that only about under 30% of the patients had a stage or a nodal status recorded. And this isn't a mere technicality. One needs to know about T3B to know how to manage T3B. To make good clinical decisions in real life, one has to know if the evidence in front of you reflects real life. Here's a table that compares the patients offered cytoreductive nephrectomy in the Hospital for the Incurables with the patients in CARMENA. Age and sex are identical, but look at the difference in performance status and risk scores. In real life, patients selected for cytoreductive nephrectomy are fitter and carry less systemic impact from the disease. The tumours in real life are different too. In real life, more of the disease is in the primary tumour and there's less metastatic burden. The metastatic burden in CARMENA was high. Might I even suggest that in real life, it looks like we have more appropriately selected patients. Ultimately, of course, the key is to know how these differences in patient health and tumour burden translate into outcomes. Clinical judgment, we're agreed, requires one to know your own results. Well, here, I've overlaid our own results at Guy's on the Kaplan-Meier curves from the CARMENA paper. The outcomes at the Hospital for the Incurables look very different from those in the CARMENA trial. 50% of patients at Guy's are surviving 3 years. Our approach does seem to be working. Survival's important, but it's not the only thing. It's also about quality of life. Patients undergoing successful cytoreductive nephrectomy may not need to start the systemic treatments straight away. Here, we've called that a good deferral. 1 in 4 may avoid systemic treatment for a whole year. On the flip side, of course, are the patients who may never receive systemic treatment because they underwent surgery and developed complications or died. 20% is a figure that's often quoted, and that was the figure in CARMENA, and we call that here a bad deferral. You can see in our practice, it's nowhere near 20%. It's a tiny percentage of patients who never receive systemic therapy. You need to know your own results. Deferral of systemic treatment may be a very valuable goal. It's easy to forget the challenges patients face living with the side effects from systemic therapy. The drugs are not benign. And you don't have to take a surgeon's word for it either. Here's what one of our own medical oncology colleagues thinks of the side effects of TKIs. And it's not just the TKIs. Here's what one of our own patients posted about living with IO colitis. Read it. It's a really interesting reflection. I think by any estimation, this would be considered a life-changing set of problems. And if one could avoid these for over a year, then probably one would jump at the chance. Deferring these sort of problems may be a very good thing indeed. I mean, the patient's perspective in all of this is, of course, absolutely vital. The world of consent has changed out of all recognition in the last 15 years. Patient autonomy is the new principle. Doctors advise, patients decide is the new mantra. So what do patients think of cytoreductive nephrectomy? Well, the patient surveys suggest that the majority do want their primary tumour resected. They don't think surgery is redundant in this area. Doctors advise, patients decide. So what about some examples? How do we apply that clinical judgment in real life? Well, here is a very large tumor in the left kidney. Patients had one episode of hematuria. Would I recommend a cytoreductive nephrectomy in this case? Actually, no. And why no? Well, there are lymph nodes, there's high volume lung metastases, and there's a right femoral metastasis. Systemic treatment needed for a clearly systemic disease. Would I offer cytoreductive nephrectomy in these two cases, both with para-aortic lymph node masses and equivocal lung CT? I would offer it, but I would only offer it if I felt those lymph nodes were removable, which in these cases they were, clearing the infradiaphragmatic disease in its entirety. How about here? Would I offer cytoreductive nephrectomy here? Not in a million years. It's a desperate mass around the IVC, biopsy, and systemic therapy. And then finally, a fascinating dilemma. So this lady had a 22 centimeter diameter renal mass, but she did have a liver metastasis and quite a bit of hematology going on. Her hemoglobin was 68. But we operated. Now, why did we operate? Well, in truth, she needed surgery to get her into a state where systemic treatment could even be considered. The performance status and all the hematology improved dramatically with surgery. It was a good decision to operate. So putting it all together, I think for me, this is the key question. Does this patient need the primary tumor treating or the metastases? And you have to decide the answer to that question. Which is the dominant event at presentation? I think if one created a set of traffic lights for clinical decisions after that, how would it look? Well, you've got to stop at the red lights. Cytoreductive nephrectomy is not the default. You need to stop and think. CARMENA has definitely told us to do that. When you're on amber, you need to assess the risk. You need to calculate it. And I think if poor risk on IMDC, probably avoid surgery, particularly if poor performance status. You need to work out the metastatic burden. Multi-site metastasis for me indicates the systemic process. And I think you do need to sense check for sarcoma or Wilms, consider a biopsy. But where the primary predominates, perhaps where all the subdiaphragmatic disease can be resected, where one isn't certain about the CT lung, might it not be a MET? Where the performance status is very good and the metastatic burden is low, or where the IVC extension is causing problems of its own, or where a good deferral of systemic treatment might be possible and beneficial, then I think surgery still has a role to play, as long as it's done well. Thank you.